Good afternoon. Is the mic working? Yes, the mic is working. Um, Welcome to the Joint Legislative Audit Review Committee's Initiative 900 Performance Audits by the State Auditor Subcommittee. We are holding two public hearings on two different audits from the State Auditor's Office today. And before I go into them, I want to recognize that this is a hybrid meeting today, and I am chair of the Joint Legislative Audit and Review Committee, Representative Jerry Paulette from the 46th District. And joining us on Zoom will be several other representatives and senators from the Joint Legislative Audit Review Committee. I know that Representatives McClintock, Barnard, and Scott are all here. Welcome, and thank you for joining us. If anyone online has a question, seated next to me is the Legislative Auditor, Eric Thomas. Eric has you up on Zoom, and if you put your raise hand feature or just wave at him, he will let me know, and I'll put you in line to ask any questions or offer comments. With that, I want to go through that. The Auditor's Office is presenting their recent reports on reducing non-emergency use of emergency systems, and secondly, improving performance management in economic development programs. I just want to say that these are both very important performance audits and very different topics, but very important for action and follow-up. Staff from the State Auditor's Office will give a presentation of these two performance audits. The performance audits discussed at this hearing were conducted solely and independently by the State Auditor's Office under the authority of legislation approved by the voters in Initiative 900. The state auditor is elected directly by the people of the state of Washington and operates independently of the legislature and independent of the Joint Legislative Audit and Review Committee, which is JLARC. JLARC members, please let me know if you have any questions using the raise hand feature. After the State Auditor's Office presentation, agency staff will be providing comments on the audit reports. I know I see some fire officials here in the audience, which I really appreciate your coming in person, and we have some online. And members will have an opportunity to ask questions of the agency responders. We will also take public testimony after each presentation. Staff have supplied information on registering for in-person and remote public testimony via Zoom on the JLARC website. So with that, we will go to reducing non-emergency use of emergency systems. Lori Raymond Garrettson and Michelle Fellows from the State Auditor's Office are presenting the report, and I believe they are remote.
Yes, hello.
Thank you. Please introduce yourselves and take us through how we can improve CARES programs.
All right. Well, good afternoon, Mr. Chair and members of the committee. My name is Michelle Fellows. I'm a performance auditor at the Office of the Washington State Auditor. With me is my colleague, Lori Ryman Garrettson, who led the audit. Before we get into the presentation, I'd like to take a moment to thank the auditees, all 8 fire agencies, for their cooperation and assistance throughout the audit. Everyone who calls 911 needs help. When it's for a true medical emergency, fire agencies, EMTs, and paramedics can respond to provide life-saving care. But when it's not, the EMTs and paramedics' specialized skills aren't put to good use. and emergency medical services may become less available for those who really need them. Meanwhile, patients who could have been cared for by a primary care provider or social worker can end up in an emergency room, contributing to overcrowded ERs with long wait times. In response, some fire agencies have established CARES programs to reduce non-emergency use of emergency systems, improve population health, and prevent injury and illness. Fire agencies develop these programs locally to meet their community's most pressing needs. CARES programs include different types of interventions, such as mobile integrated health, community paramedicine, and co-response. They operate under the state law that authorized CARES programs for fire agencies in 2013. Although several organizations are involved in emergency medical services, such as the Department of Health, none identify, track, or regulate CARES programs. At a high level, this audit had 4 main results. Across Washington, fire agencies operate more than 50 CARES programs, yet other communities could benefit from a program. Programs face many barriers, including funding challenges. Programs track their performance, yet some are not meeting the state's requirements in this area. And to further reduce non-emergency use of emergency systems, insurers, hospitals, and fire agencies can work together. We conducted this audit because CARES programs can improve patient outcomes and lower costs. Some studies have shown programs improved patients' health, such as by reducing barriers to healthcare. Other studies have shown these programs safely and effectively reduce the number of ambulance trips, ER visits, and hospital readmissions, generating significant savings for healthcare systems. The audit sought to identify the locations and characteristics of existing CARES programs, areas where programs may be needed and the barriers to establishing them, and opportunities to measure program performance. To do so, we surveyed the state's fire agencies and conducted a case study of 8 CARES programs. The audit identified 52 CARES programs led by a fire agency, as shown on this map. Some of these programs also partnered with other fire agencies. 2/3 of Washington's counties led at least one program, which are shown here in green. Notably, King County led 11 programs, while Pierce and Snohomish counties led 4 programs each. Even less populous rural counties, such as Columbia, Garfield, and Ponderay, had a CARES program. However, other counties, including Stevens and Yakima, lacked a program. The CARES programs varied in the services they provided. Some of the most common services included outreach to people who repeatedly call 911 to connect them with services. This was done by 98% of programs that took our survey. There are also fall assessments or visiting people's homes to identify fall risks, like a rumpled area rug, case management to help coordinate care for people with complex needs, and overdose response to help prevent overdoses for people with substance use disorder. In terms of staffing, CARES programs were comprised of social workers, EMTs, paramedics, nurses, and other types of professionals. This means if you are a client of a CARES program, the people who would show up at your home would depend on the type of program offered in your area. So if you live in Port Angeles, 2 community paramedics or EMTs would arrive. They would help with safety assessments, chronic disease management, and connecting you with needed resources. If you live in Kent, a nurse partnered with a social worker would arrive. The nurse would help with navigating complex medical needs, while the social worker would help with concerns like housing or food insecurity, substance use disorder, or behavioral health issues. If you live in Spokane, 2 social work students would likely arrive. They would complete a comprehensive needs assessment and connect you with needed resources. The most important funding sources for these programs was dedicated revenue from local governments. 3/4 of programs receive funding from their fire agency, city, or county, including voter-approved levies. over half of the programs receive grant funding, whether from businesses, nonprofits, or government. Many programs used a combination of both sources, a mix of local government funds and grants. The Puget Sound region has many CARES programs, while other areas of the state need and want one. Statewide, almost 1/3 of the fire agencies that took our survey already participated in a CARES program. These fire agencies were based primarily in urban and suburban communities. Among the 2/3 of fire agencies without a program, almost half said their community needed one, as shown in this first chart. Despite this, only 12% of fire chiefs without a program said their agency was likely to start one, as shown in the second chart. This is due to many barriers, which Lori will go over in the next part of the presentation.
Thank you, Michelle. My name is Lori Ryman Garrettson. As Michelle mentioned, fire agencies face multiple and often significant barriers to starting CARES programs, as suggested by the 76 out of 162 survey respondents who said their community needs a program but does not have one. The most frequently mentioned barrier was insufficient funding. This was not only a barrier for 78% of survey respondents whose community needs a program, but it was also a challenge for many existing programs. In fact, 72% of existing programs see a moderate to high risk of insufficient funding in the next 3 to 5 years, as shown by the orange and red parts in this chart. Another significant barrier is hiring the skilled professionals these programs need. This was a barrier for more than 1/3 of survey respondents whose community needs a program. Challenges hiring skilled professionals were due to multiple causes, including a nationwide shortage of EMTs and paramedics, including in Washington. There's also a nationwide shortage of nurses. With that, many nurses may not be interested in working outside of a traditional clinical setting, as the nurse in this picture is clearly doing. Also, social workers can be an asset to CARES programs, but as with nurses, this is not a common career path. Another significant barrier for rural fire agencies, cited by half of all survey respondents whose community needs a program, is that many are volunteer-based. Another common barrier, cited by more than 1/4 of respondents whose community needs a program, was the absence of guidance on how to get started. Another barrier, specific to community paramedics, is that they're limited in the services they can provide due to the absence of statewide expectations. This results in county-level officials having significant influence over CARES programs, including deciding if fire agencies can even start a program, and also determining the services that programs can provide. In practical terms, this means that community paramedics in some counties can administer antipsychotics and medications to manage opioid use disorder, like buprenorphine, while those in a neighboring county cannot. Some states have established statewide expectations for their community paramedics, which helps address issues of regional variance. Several, including California, Colorado, Maine, and Minnesota, have codified in state law the specific services community paramedics may provide. Delaware took a different approach and required its equivalent of the Department of Health to develop standards for the state's programs. In either case, these state-level practices address issues of regional variance because they apply equally to community paramedics across the state. State law does not impose many requirements on CARES programs, except that programs must track any reduction in avoidable ER visits and repeated use of 911. The audit found that nearly all programs collected and analyzed data to gauge performance. However, only half tracked both required measures. Program managers offered several reasons why. Some were unaware of the requirement. Others said data analysis was not an area of expertise, and the limitations with their software made it hard to track these reductions. Also, ideally, a program could reach a point where 911 crews are quick to identify and refer people who could benefit from their CARES program. If that happens, these patients will never generate a pattern of repeat 911 calls. We would note these reasons point to the absence of centralized coordination, as Washington lacks any statewide agency or organization that ensures all programs are aware of legal requirements, provides assistance dealing with technical issues, and advocates for any potential needed changes. Fire agencies typically establish CARES programs to make better use of their own resources and to benefit their communities. However, these programs can also provide significant benefits to insurers and hospitals. For example, a private insurance company could easily pay $1,200 to $1,800 for an ambulance transport and ER visit, and that's before the cost of any care or treatment the patient receives. If, instead, the insurance company sends a home health agency nurse to the patient's home, it would likely cost the insurance company about $320. But if a nearby fire agency sends a community paramedic to the patient's home, both the ambulance ride and ER visit can be safely averted, and the insurance company would pay nothing. CARES programs not only save money for private insurers, but they also save money for the state's Medicaid program. In the same way that CARES programs save money for health insurance providers, they also save money for hospitals. Some avoidable ER visits are paid for by patients and private insurance, but 7 out of 10 are paid for by Medicare or Medicaid, which reimburse hospitals at rates below the actual cost of care. This means hospitals are likely to lose money on most avoidable ER visits. Also, hospitals face financial penalties from the Centers for Medicare and Medicaid Services if they have high readmission rates. Successful CARES programs replace high-cost ER visits with low-cost home visits, and they can also lower hospital readmission rates. However, this shifts costs from hospitals to fire agencies. Hospitals could rebalance some of the financial burden by rededicating a portion of what they would have spent on avoidable ER visits, as well as penalties related to high readmission rates, to their local CARES program. Hospitals can also support CARES programs by providing them access to relevant patient records. Complete and accurate medical records promote patient safety and facilitate coordination between care providers. However, some case study sites cited barriers to accessing medical records for their patients. The fire chief at one case study site described getting access as a Herculean effort, requiring 4 years of ongoing communication with the hospital and a very tech-savvy community paramedic. In addition, 3 out of 8 case study sites had no access to patients' medical records, and one program manager said this was one of the biggest barriers the program faced. Our audit has several recommendations, including 2 recommendations to the legislature. First, we recommend the legislature consider requiring private insurance companies to develop ways to reimburse CARES programs. The Office of the Insurance Commissioner just issued a report regarding this question, and it recommended considering coverage of these services in concurrence with another report on EMS services by the Washington State Institute for Public Policy, which will be completed in June 2026. Second, we recommend the legislature convene a work group for CARES programs across Washington. This group should include representatives from a wide range of CARES programs, both large and small, serving various regions of the state. Responsibilities of the work group would include drafting statewide guidance for CARES protocols, determining standard measurements for different types of programs, determining if Washington should recognize community paramedics as a distinct category of providers, and determining if the Department of Health's role in supporting CARES programs should be expanded. We also have recommendations for the Washington State Association of Fire Chiefs, the Washington State Hospital Association, the UW School of Social Work, the union that represents firefighters, and those CARES programs that lack access to patient medical records. That concludes our presentation, and we would love to address any questions that you might have. Also, as Representative Pollitt noted, representatives from the case study sites are available both online and in person to address any questions you might have about their programs. Thank you so much.
Thank you very much for the presentation and the great work doing the performance audit. At this time, what I'd like to do is ask if any of the committee members have questions for the presenters, and then ask the agency representatives if they would like to speak. And I do know we have one assistant chief who has asked to testify, and then ask the legislators online if you have questions for both the presenters or the people from the agencies and testifying. So any questions for the presenters to start with? Now, don't be shy, members. Not seeing any hands go up. If no one else does, I'm going to ask a question. One of the more interesting findings of the performance audit in terms of financing of CARES programs has to do with the accountable communities of health and the Healthcare Authority and Medicaid reimbursement. When I read just the summary, I was curious as to, is there some sort of barrier that exists because the accountable communities of health, 9 entities across the state by region that coordinate healthcare access, they measure and prioritize investments in their regions based on reducing emergency department visits. And that's very important for Medicaid. And so I was surprised when I read that only 10% of the agencies that you surveyed utilized funding from the healthcare, accountable communities of health. Is there any requirement, or perhaps should there be a requirement, that the ACH entities distribute funding? Since, as you note, the savings greatly rebound to the rest of the healthcare system rather than the fire department that provides the service. Why is it that only 10% received reimbursement this way? And what's the obstacle that you found? And then when agencies speak, if you could also share your view on this, I think it would be very helpful for us to examine whether or not we should be asking the Healthcare Authority to require some form of reimbursement or remove obstacles. So
responding to your question, so first of all, the 10% that is cited in the report is direct reimbursement from Medicaid for the treat and refer program. And what we heard from fire chiefs that we spoke with during the audit is that some of them are no longer seeking that reimbursement because the reimbursement rate, which is $115, is such that they don't consider it worth the effort it takes to seek reimbursement. So that 10% is specific to direct reimbursement from the Medicaid program. In terms of the accountable communities of health, some of the accountable communities of health are very supportive of the CARES programs in their regions. And I believe it was 26% of our survey respondents said they were receiving some sort of a grant directly from their accountable community of health, so that it's separate than the Medicaid reimbursement. And in fact, one of the accountable communities of health, Greater Health Now, is having a symposium on Friday to gather people who are involved in this type of work. So some of the accountable communities of health are quite involved in supporting CARES programs. Does that answer your question?
Well, it's very helpful clarification. Thank you. But it still means that 75%, 3/4 are not receiving any funding through the accountable communities of health. And is there a barrier that we should be addressing, or obviously the Medicaid reimbursement rate that you cited is a real barrier if it costs more to apply for Medicaid reimbursement than you're getting. But what about the ACH support?
We didn't really look into requiring the ACHs to support their CARES programs. My best understanding is part of the beauty of the ACH model is that they're able to respond to local needs and they have some autonomy in doing so. Does that answer your question?
Yes, and then I'd love to hear from the agencies when you come up about your experience. Thank you. In that case, if not seeing any other questions, we have present today Steve Larson, EMS Captain, Bellingham Fire Department, Nicole Picknell, Community Paramedic Captain, South County Fire, Daryl Sharp, Fire Chief, Port Angeles Fire Department, Bruce Carson, Fire Chief, Puget Sound Regional Fire Authority, Tony Troutner, Governance Board Chair for the Puget Sound Regional Fire Authority, Ann Raven, Administrative Battalion Chief, Integrated Medical Services Program, Jim Sharp, Fire Chief, West Pierce Fire and Rescue, and Mike Jackson, Assistant Chief, Clark Cowlitz County Fire. First off, for the people who are here in the room, would you like to come forward and offer any comments? And with my great appreciation of your taking the time to appear here personally, please come forward and introduce yourselves.
Do I have to press? Okay, I'm on. Hi. Yeah, thank you, Mr. Chair and members of the committee. My name is Nicole Picknell. I am a fire captain for South County Fire. History of being in the fire service for 38 years, paramedic for 35, 20 in this state. I currently run our community resource paramedic program and have been assigned that duty for the last 5 years. I am in support of the audit and their findings, and a direct answer to your question about the accountable communities of health. We are one of those agencies that utilizes those funds. Our biggest gap is it's 1-year contracts. So we do not know from year to year if we can sustain our program. Our program before COVID had 250 clients. We are now over 3,000, and that's the ones that we have repeat 911 use. That doesn't include people that we find and we solve their problem before. We can actually predict what's going to happen. So that's the 3,000 that we work with, and that's new clients this year. When we have 1-year contracts, it's hard for us to sustain if we're going to have a program next year. 85% of my program is ran on grants. Most of them are 1-year funding. So sustainable funding would be the number one significant barrier for us. Also, another thing about the audit that was found is communication and access to systems to understand the client and patient's needs. If someone needs care in Clark Cowlitz County, then they move to my area. There's a gap in us with the client care, and for us to understand that we've been working with the same individuals, so they start the program over. Something to be aware of why this is so important. In Snohomish County, sometimes we have 3 to 7 hour wait times on the wall before an ambulance can get a bed in the ER. These are clients that we can handle and give them the appropriate resource right from their home with them on the phone and take them to the appropriate destination. But back to your first original question, grants are difficult to sustain year after year when we're working with 3,000 people. And I have a team of 14, and every year the thing that keeps me up at night is if we're going to have a program next year. That would be my answer, so thank you.
Thank you very much for going through that in detail. Appreciate it. And would you introduce yourself?
Thank you. Mike Jackson, Assistant Chief with Clark Cowlitz Fire Rescue. We have similar experience. We have, in answer to the question regarding the accountable communities of health, we work with Swatch in our region, and actually they funded the initial start of our program as a pilot program in 2000 as one of their early programs. We have continued to receive some funding from them for our program that supports part of two positions. As Captain Picknell pointed out, the sustainability of that is in question and is on a year-to-year basis. And with some unknowns about the future role of the ACHs, that certainly leaves some question and doubt as to the reliability of that funding. We too were fortunate to participate in the program and the audit from the state auditor's office, supporting the recommendations that they found, and certainly found it to be a useful exercise to look at programs around the state. I think the programs we have found make a remarkable difference for some of the most vulnerable folks in our communities. Our program is a little bit unique. We are funded almost exclusively with funding outside the fire district, but it is all different siloed funding that is not guaranteed year to year. So we partner with both hospitals in Clark County, and we're pleased to report that recent numbers that we saw from the Association of Hospitals for the state of Washington reported that the lowest percentage of avoidable emergency department visits was in Clark County, based off a county-wide assessment and looking at counties across the state. So we don't know exactly what part of that our program played, but we have been partnering with the hospitals for about 5 years now, taking direct referrals from them as well as our operations team. So we're confident that we certainly played a role in that avoidable ED visit statistic there. For us, the fire service is certainly a good fit, just with the can-do attitude and the tenacity of our culture with solving unique problems with the tools that were provided. With the funding being siloed and short-term grants, there's been an interest in programs lately that has pushed for lots of startup funding, but then once you start up, sustainable funding becomes an ongoing issue there. So I think for us, we find it being a very effective use of dollars, as the audit has pointed out, with having great impacts and not only helping the healthcare system, but with our acute response program, we're impacting avoidable jail detentions and helping the criminal justice system with diverting folks with behavioral health emergencies out of the criminal justice system as well and getting them more appropriate direct treatment. So I think that's a piece of the program. Our program is funded partly by the ACH, partly by contracts with the hospitals, and then we have a remarkable relationship with our area agency on aging, and they have some funding specific for the medication reconciliation part, falls reduction, as well as transitional care for older adults transitioning out of hospital care back to the home. So we have partnered with them for a number of years on grant cycles to help support our program and common mission along those topic lines. And then on the acute response side, we work close with our BHASO for crisis service response and trying to intercept some of those folks earlier on in the system and get them more direct connection to services. So anyway, thank you for the opportunity to be here, and happy to answer any questions if there are any.
Let's hear from 3 people who are online, and then we'll open it up for questions for all the presenters from our legislators. So first, I have Steve Larkin, Bellingham Fire. Is it Steve Larson? Excuse me.
Yeah, good afternoon. I don't have a tremendous much more to add than the folks ahead of me here. And aside from just the same message that funding is typically our crutch as well, and why it's provided from our EMS levy and our city. It's always the unknown if the program's sustainable because it's not our minimum operations. And then with that said, you know, we need more, we could use more community paramedics because the volume of clients that are unable to be served is so high. But yeah, I appreciate the audit and the audit work.
The paramedic, well, all the providers, social workers, nurses, we have great shortages. Paramedics can do a great job adding to the depth of response with authorization, and the Workforce Development Committee is certainly interested in how we expand the training opportunities and pipeline there. Next is Jim Sharp from West Pierce Fire and Rescue.
Thank you. I don't really have a lot to add either. I think most of it has been said. I will just reiterate kind of the key piece that these programs are unique to each community. And where the need exists in that community, they're a fundamental program that really can make a difference. However, like everyone else has said, funding becomes the problem because there is no dedicated funding for this. It took us a long time to get our program off the ground because we were determined not to do it through grant programs and other funding that may not be there. We wanted something dedicated. And so we're fortunate we have a fairly supportive community that got behind this idea, and they've given us the funding to be able to do it. But we can't expand it very easily. It's, there's a lot more need out there, but we're kind of at capacity with the program we have now. And until we can find more funding, it makes it really challenging for us to expand and meet all the needs that are out there. So yeah, funding is key. Dedicated funding is key. I know most of these programs work on grants and a variety of cobbled together funding sources. And that's not an easy way to run a critical program within the community that supports some of the most vulnerable people.
Right. Thank you. And Ann Raven with the Integrated Medical Services Program.
Yes, hello, thank you. I don't have much to add either. All of the successes and problems, I think we share pretty universally with the other CARES and mobile integrated health type programs. Funding, sustainable funding is always an issue, and it is, as Captain Picknell said, the thing that keeps me up all night is, are we going to have a program next year and the year beyond, especially as you look at hiring people and putting them in these positions and they're going out and doing very difficult work. I want them to know that their job will be there next year. So it is critical. I see it with my own eyes every day that we have these programs and keep a lot of these patients out of the ER, out of the jails. And we also have very long wall wait times at our emergency departments that unfortunately are filled up with patients that don't need to be there, that we could manage in their home with the appropriate resources.
Right.
Thank you.
Well, thank you. And thank you to all of you for making time today. You are providing incredible service that every resident of the state relies on. We really appreciate it. One question for any of you to answer is, are any of the departments planning on utilizing the new public safety sales tax authority to fund part of your programs?
I can speak on behalf of fire districts specifically, which several of us represent. It's simply not a funding opportunity specifically for fire districts. That would have to be coordinated with the municipality for the sales tax. So in our case and the other fire districts, it's not really an option.
Right, so you would need to have a contract or something to get funding through, because it's not a sales tax for the fire districts.
Correct.
Right.
In our case, our municipalities are looking at it. We have 3 municipalities within our fire district that are incorporated into our district. So they're looking at that as a revenue stream for law enforcement services generally.
Well, obviously, I encourage discussions about that, and I also would like to say I encourage programs to take the audit and its recommendations around to local elected officials and legislators in your who represent you, and to discuss the findings. Are there any other questions from or comments from members online? Again, thank you very much for spending time with us today and for the great programs you're running. And thank you to the state auditor's staff for this audit.